afternoon. The time has begun, and I wanted to introduce one of our second-year fellows, Mark Elliott, who got his bachelor's in political science at the University of San Diego, and then followed in somewhat of the family business, going to medical school at Cornell in New York City, and then the residency here at UCSF in the adult program, and is finishing his second year in our child fellowship. One of the opportunities that we give our fellows is to choose a topic that they will do their grand rounds on. And some people have some consternation doing that, and others see this as a stepping stone into the next phase of their career. And when Mark told me he wanted to present on the opioid situation, I was very enthusiastic about that and provided some references for him. And then just yesterday, I got a news flash from the American Psychiatric Association's communication department. It says, Eric Hargan, the acting Health and Human Services Service Director, last Friday signed the extension of the opioid public health emergency declaration for another 90 days. The White House said in a statement, quote, the president has used this as the bully pulpit to bring national attention of this crisis issue, not only to every American, but also to members of Congress, state and local officials, and his entire executive branch. So we couldn't be in a more poignant and favorable place for this presentation. Mark.
Thank you very much, Dr. Sikorsky, for the kind introduction, and thank all of you for being here. I really appreciate you being here. And yeah, as Dr. Sikorsky said, I've been excited to give this talk. I think it's a really important issue, and one that, as Dr. Sikorsky also pointed out, has been really on the minds of a lot of America, and it's gotten a lot of press. I feel like every day there's a new story about the opioid epidemic. President Trump recently called public health state of emergency the opioid epidemic, despite not really diverting any funding to it or doing anything meaningful to address it. But it's been recognized as an emergency. I think we're all aware of that at this point. And psychiatry has an interesting role in all of this. In some ways, we're the first line of treatment for opioid addictions. I know most of us here don't actually directly work with addicts, but psychiatry as a whole certainly does. And there's a huge we have a huge task ahead of us to try to treat all of these addicts that have been created across the country. And most talks by psychiatrists about this have really focused on treatment, and I do think that's hugely important and has been very effective, and we're learning more ways to treat people with opioid use disorders. But today I'm going to argue that is really not enough, and that while we can treat as best we can, even if we could identify and treat all of these people, we're not curing them of these issues. And as far as if things keep up how they have been, we really do not have the capacity or the tools to really help these people that are increasing in numbers very quickly and still are. So I think that we're in a unique position as psychiatrists and mental health professionals, as the experts on addiction, at least relative to our colleagues in other fields, and people are looking to us for some direction as far as how we should be addressing this really clear problem that's presented itself. And I think that we have an obligation to educate our colleagues in other disciplines on how best to address this. And today I'll be arguing that the only way that we can really hope to meaningfully curb and hopefully turn this epidemic around is to prevent people from becoming addicts in the first place. I think that's a pretty intuitive idea, but at this point has not really gotten a lot of traction in terms of policy or in terms of guidelines. I have no disclosures. And just want to say I love questions, so please, if you have them, throw them out. Just raise your hand. And, I do like to have it so it's just not a pure monologue if you guys have questions. And as far as learning objectives today, I really have three. The first is to go through where we are in the opioid epidemic at present and a bit about how we got here. The second is to show what we know about how risky these medicines are when prescribed to particularly opioid naive individuals, and what we found out really pretty recently about these risks. And the third is to argue that the most effective way that we can possibly turn this around is to decrease the number of prescriptions that are going to people who have not had opioid prescriptions in the past, the so-called opioid naive population. So this is where we are. It's kind of a terrifying graph. It's a little hard to read, I apologize. But we've seen this really meteoric increase in opioid deaths in this country over the last 20 years or so. This graph shows a ninefold increase in deaths by opioid overdoses over the course of 17 years, which seems to me like a giant increase for sure, and something that we should be focused on. We had in 1999 there were a little less than 6,000 people that were killed by opioid overdoses, compared to almost 55,000 in 2016. It certainly seems like a giant jump. For me, numbers like this are a little hard to anchor. And I see 54,000 deaths in a year from something, and it sounds like a lot, but I don't have a great sense of what to compare that to. And it got me thinking, people call this an epidemic, and I think that's mostly kind of a media term. It has some more technical definitions, but for the most part, it's kind of a media term, and it got me thinking about other epidemics that we've endured in my lifetime, and I wanted to kind of compare them. The first thing that came to my mind, I think in part because I grew up in the Bay Area and have been practicing in San Francisco, is the AIDS epidemic. The AIDS epidemic is one of the most devastating, if not the most devastating, certainly infectious disease epidemic in the United States in my lifetime. And to be honest, I was pretty shocked to find out that in 1994, which was the peak of the AIDS epidemic in the United States, we lost about 40,000 people, which even controlling for the population increase since then is still significantly more now that died in 2016 from overdoses than died at the peak of the AIDS epidemic in this country. So that's a bit of perspective, and it's kind of terrifying. And to make another comparison, car accidents have been, for my lifetime, and I think most of our lifetimes, have been the number one cause of accidental injury in this country, and accidental death has been from car accidents. And just over the last few years, opioid overdoses have crossed even car accidents. We talk a lot about texting and driving, drunk driving, and distracted driving, all these things. And I think it's super important, and clearly motor vehicle accidents remain a big problem. And yet, the opioid epidemic has overtaken it in terms of the rate of deaths in 2016. Yeah.
Are those data assumed to be accidental?
They attempt to be, yes. They come from the CDC, and it's intended to exclude suicide, although there's almost certainly some sort of risk factor. So, and getting to suicide, something a little more near and dear to us, and something that as mental health professionals we're kind of obsessed with suicide, and I think justifiably so. I mean, it's long been the #1 cause of mortality from mental illness in this country, and might still be, depending on how you parse it. But and we all know that, I mean, I think it's debatable if there's a suicide epidemic per se, but certainly it's a very serious problem, and something that has been, you know, a big focus of psychiatry. And yet, once again, suicide in 2016 was a little less than 43,000. So opioid overdoses over the last few years have eclipsed even suicide in terms of death rate.
Is that in the US?
It's just in the US.
43,000 people kill themselves every year in the US?
Approximately in 2016,
Wow.
yeah. So big numbers there too. I mean, it's still a lot of people. And yet, with this crazy meteoric rise that we've seen in opioid overdose deaths, it's eclipsed it. And I mean, it's complicated to call this the sort of #1 source of mortality for mental health, for mental illness. But it's tempting for me to say that anyway. I don't quite find enough data to say that conclusively, but at the very least, this is pretty scary, and it's a pretty big deal, I think. And you know, it's easy to talk about death from these because we have pretty good statistics relative to other things, and it's, you know, kind of provocative to talk about death, which is why I brought it up in the first place. But as psychiatrists and mental health professionals, we also understand that death is really the tip of the iceberg from substance use disorders in terms of suffering and morbidity, the amount of occupational and relational hazard that comes from being from chronic opioid use of all kinds, including you know, prescribed use as well as a use disorder, comes with an enormous cost that is very rarely death. Sorry, my notes are a little wonky from the computer switch, but the National Survey on Drug Use and Health is a survey that looks at drug use trends in the United States, and found in 2016 they estimated that approximately 11 million Americans misused opioids, meaning that they used them other than prescribed and presumably not for pain per se, or at least not with a doctor's prescription. And so given that number, about 0.4% of those people actually died, just using kind of simple arithmetic there. And they estimated in 2016 about 2.1 million had diagnosable opioid use disorders. So about 0.6% of the population is struggling with that. And that number, about 2.5%, died in 2016, which is a high number, but still the vast majority of these people aren't dying, but they are suffering. And you know, I think it's really a pretty extraordinary problem in terms of scale. It's really affecting a vast number of people in this country, and I think it's important to address it, I think it's fair to say. How did we get to this point? It's a complicated answer to some extent, and I'll be simplifying it to some extent in this talk. But I think it's important to think a little bit about the history, and thank you, Dr. Sikorsky, for pointing me toward it, in how we did get here. And I think it's hard to argue, looking at the history, that prescriptions have been a big driver of this problem of the expanding opioid use in this country. Prescriptions from providers in the United States. We saw, and unfortunately, data weren't really well collected before sort of 99, 2001 in that area, so we don't really know what things were like before then. But we saw about a threefold increase between 2001 and 2011 in the mass of opioids that were prescribed. Both the number of prescriptions increased dramatically, and also the size of the prescriptions, the number of morphine equivalents in those prescriptions was increasing dramatically during that time. And thankfully, 2011 was its peak, and it has been falling consistently ever since then, I think because of a lot more awareness and caution around these medicines as the costs of their sort of broad use have become more clear. But we're still roughly at about twofold where we were in 2001. While we don't have the data, one has to imagine that it's quite a bit more than that when comparing it to the 80s or even the 90s, where prescription rates were. So we had this big increase in prescriptions from doctors, and it raises the question of why. Why did these numbers increase so dramatically in such a short period of time? And again, it's a pretty complicated story, and I can't get into all the details, but I really do encourage folks, if they're interested, to read more about it. I think it's an important case study in the way that the pharmaceutical industry has control or power over doctors' prescriptions. But in the 1990s, it was recognized that there was yet another epidemic, a pain epidemic, and particularly an undertreated pain epidemic. And pain specialists and various advocates were pushing for that to be fixed, for people to be more aggressive about identifying pain and treating it when they do identify it, because there was an enormous amount of morbidity and even mortality from pain and acute pain and chronic pain. And there was a big movement to really change the way that we addressed pain and dealt with it. In 1996, the American Pain Society released a report suggesting that pain be the fifth vital sign, so that when nurses and doctors are taking vital signs from patients, that part of that process would also be to ask them about their pain, to help identify when pain was there and to quickly treat it. Along with this, I'm hoping, audio here will be. We'll see it. Hopefully I have audio. We'll see. But in parallel with this, also in 1996, a company called Purdue Pharmaceuticals released a new formulation of an old medication called Oxycodone. They made a long-acting preparation that was supposed to last for 12 hours and called it Oxycontin. It was supposed to be nice because you could give all-day pain relief, and was also purportedly less addictive than its instant-release counterparts because of this long-acting formulation, and it purportedly harder to abuse because of it. I want to share with you one of the ads that was released during that time, which hopefully will work. Nope. Let's see. USB2 audio. Well, this no. Looks like Will is not here. Well, I'll give up. But it's an ad from Purdue that came out in 1998, basically extolling the wonders of opioids in being the most effective treatment that we have for opioids, and also being really not very addictive at all, arguing that they have a long history of being of being associated with addiction, but in fact people who are treated for pain with these medicines are addicted at much less than 1%. There's a lot in that ad that is at best questionable, and at most, at this point, outright wrong, as has been shown to be. But he also did an interesting thing that's a kind of classic sales technique, that he started with a kind of obviously true statement that opioids are the most effective medicines that we have for pain, which is maybe not an absolute truth, but pretty close to true. They're incredibly effective for reducing pain, especially in the short term. And then he followed that up and kind of sandwiched this idea in between these other ideas that are quite a bit more questionable, like the rate of addiction of people being treated with these medicines is much less than 1%, he says. He also says that they don't wear out, that these meds, you can keep prescribing them and they keep working indefinitely, and there's no problem with that. And the third thing he said was that there were no serious medical side effects of being prescribed these medicines for indefinitely for pain. And sort of to his credit, we didn't know back then. In 1998, there were essentially no data to answer any of these questions. And even now, it's pretty minimal as far as what we really know. And today, the second two are kind of outside the realm of this talk, but I want to talk about this first claim, that the rate of addiction is much less than 1%, as he said. And it wasn't really until last year that we had any data whatsoever to guide us in understanding how risky these medicines really are in terms of addiction. In 2017, in the New England Journal, this article was published looking at emergency physicians' prescribing habits and looking at people who visited the emergency room who, at least to their knowledge, had not been prescribed an opioid before, or at least within the last 6 months, that then received an opioid prescription from the emergency room. And they followed up with them a year later to see how often, or this was all retrospective, but they looked at a year later to see how many of them were still using opioids chronically at that point. So people who were not using opioids before, who then a year later were filling regular opioid prescriptions. Their estimate of the risk of giving one opioid naive person one prescription for opioids in the emergency department was about 2%. 2%, it's a little bit of a hard number to interpret. Once again, it kind of sounds small, I think, at least to me. But I think, especially in terms of public health, it's really difficult to meaningfully interpret these numbers. And I want to talk a bit about ways to think about it. One thing that I want to introduce that maybe you review for some of us is the concept of number needed to harm, which is sort of the dark side of number needed to treat, which gets a lot more play, I think. But number needed to harm is the number of people that need to receive an intervention in order for one of them to be harmed by it. And from this study, their estimate, and it's not a perfect estimate, almost certainly, the number needed to harm about 48. So what that means is for every 48 people that are exposed to one of these medicines, one of them will walk away with chronic opioid use, at least at a year. And admittedly, this is not the same as addiction, and I don't mean to conflate them, but right now, these are the best data that we have to kind of estimate these risks. And still 1 in 48 doesn't seem like a lot until you think about the millions and millions of opioid prescriptions that are going out every year. And this stuff scales and it goes up, and you can see that even though we have cut back the prescriptions, that there's still, that the death rates keep rising. And that almost certainly that this is that 2% does really get magnified when you're talking about population scales. There was another study too that came out in this last year that looked more broadly at prescribing patterns. They did look at emergency departments, but also looked elsewhere and got a little bit more granular data. And most of their data were pretty consistent with number needed to harms around 20 to 100 or so, 20 to 90 really, with sort of 50 mark being about roughly their estimate for the general population too. But this study showed just how much heterogeneity there is in this risk too, with one particular extraordinary statistic being with Medicare disability recipients. So these are people who are not old enough to qualify for Medicare on its own, but are disabled enough that they get Medicare. So these are disabled, relatively young people, at least compared to the Medicare population. And their number needed to harm from, again, one exposure to an opioid in the emergency room setting was 7, which is like have chills. Like, it's a horrifying number if you're familiar at all with number needed to harms in general. It's super high. So 1 in 7 of these folks are walking away, in this case at 18 months, with with chronic opioid use. And at the same time, 1 in 7 could be kind of an acceptable risk, one might think, if the other 7 are just getting great pain control and that's working out. But even back to this 1 in 48, this number needed to harm of 48, I want to put this in a little bit of perspective. I think most of us aren't really used to looking at number needed to harm. And I want to do a little thought experiment with you, if you'll humor me. So what would you choose? The first being, we'll call it chronic opioid use. Not necessarily addiction, but going from not using opioids to using opioids every day, kind of indefinitely. And the other choice being a non-fatal heart attack, a heart attack, which nobody wants to have a heart attack, but chest pain, you might get some shortness of breath, you might have to go to the emergency room, but it's not killing you. You might lose a little bit of your cardiac function, but you go home and you're not dead. I need to think about which one you would prefer, to be a chronic opioid user versus having one incident of non-fatal heart attack. And the reason I bring it up, it's kind of a classic story in pharmacology, which is Vioxx, which is a non-steroidal pain med that was released in the 90s, primarily marketed toward arthritis, that became pretty infamous for killing people. I found this cute little graphic, the arthritic pain alleviated, even if it kills you, It turns out that it never was shown to kill anyone, Vioxx, they never showed any increase in mortality, but they did show an increase in non-fatal cardiac events. And the number needed to harm from Vioxx was estimated at about 333. And it was banned from the market. We still can't use it, even though there are a lot of pain management specialists who mourn for its loss because it was a very effective med that people really liked, but it was deemed to be an unacceptable risk to be prescribed to the general population. And I'm not sure that was the right move. I'm not saying that it is, but just to give kind of some context as to what kinds of the magnitude of harms we sometimes avoid and sometimes ignore. And again, I mean, this is mostly a problem because there's so many of these prescriptions going around. If it weren't, these really low rates of individuals getting addicted wouldn't be such a big deal. But as it is, we're still seeing this massive increase in opioid deaths in this country, which so far seems to be accelerating, if anything. We don't have 2017 data yet, but this is the trend that we have so far. So what are we doing about this at present? It's a big deal. People talk about it all the time. People are releasing guidelines and recommendations. The CDC has, the AAAP has, American Pain Society has guidelines. And they all are trying to address this problem. And so far, the vast majority of the recommendations are focused on opioid replacement therapy, things like methadone and Suboxone. Medicines like Naloxone Naloxone in particular, to reverse overdoses when they do occur and prevent death. And the third being prescription monitoring programs to identify people who are misusing these medicines and doctor shopping and presumably to decrease their own sort of liability and also diversion, that a lot of these people are presumably diverting a lot of these meds. And I want to argue that these things are crucial and important in working with this problem, but also I think totally insufficient to reverse what's already happened, and to really hopefully start having these numbers start decreasing rather than increasing. So just to go through them, the first thing is methadone and buprenorphine and all of its formulations, and these are clearly very important interventions for addiction, as far as or for opioid addiction. As far as evidence-based interventions, they're probably the best we have or close to it. They decrease the amount of illicit opioids people use almost certainly, and seem to have a positive effects on outcomes. and functionality for people, and they get them connected with clinics, and there's a lot of benefits to these. And this has been a huge part of what the guidelines have been recommending. We continue to ramp up. And while methadone has actually been decreasing year over year for quite some time, buprenorphine has not. It's been really very quickly increasing. Over the last decade or so, we've had about a 20-fold increase in buprenorphine prescriptions. And I think that's fantastic. I think we should do more of it. And it's really important. Again, I don't think it's likely to turn things around, but I think the more the merrier, and the more people we can get treating people with medicines like buprenorphine, the better.
I have a specific question about
Yes,
that.
please.
Is there any movement in the field to make becoming certified to prescribe Suboxone more accessible? Because as far as I know, you need a separate certification to be able to prescribe, and it's very hard for people to find providers who can, well, first of all, it's hard to find a psychiatrist, right? And then to find a psychiatrist who prescribes Suboxone is really, really, really difficult.
Right.
So I'm really excited about your prevention part of the talk, and I think this part is really important too. So I'm wondering if there's any shift in the field, any efforts to make this more readily accessible for people.
So I'm not aware of any specific. I mean, you brought this issue up of how the like X part of the license, right, and it being difficult to get. And while I've heard a lot of murmurings about that being crazy and unjustifiable, I've not heard anybody talk about really trying to get rid of it. What I have heard is really trying to push buprenorphine therapy more into the primary care setting. So we have more soldiers on the ground, people who can do it, because you don't need to be a psychiatrist to prescribe buprenorphine, but it so far has been mostly kind of our jurisdiction. And so that is what I'm aware of as far as movement in that direction. I think it's a really important issue because the number of addicts that we have is constantly increasing and might be accelerating, and we're going to need a lot more people to do this. Psychiatry really doesn't have the capacity to. So yeah, that's what I know about the current state, but there might be more. Excuse me. Naloxone is another important part of this. Basically giving people an option in case somebody does overdose to revive them safely. And I think this has a lot of promise in helping prevent opioid deaths, and is really kind of in its early stages of getting rolled out. Excuse me. The third thing is prescription monitoring programs, like Cures that we have in California, which I think is an important part of this, and certainly in terms of diversion, I think is probably the biggest place where this one is likely to have an impact. As people, it makes it much harder to doctor shop and kind of hoard opioids to then be able to sell or give away or whatever. I'm a little bit skeptical that it's likely to do much in terms of the burden of disease of opioid use disorders in this country, but I think all of these things are crucial, really, in addressing this. But despite these, and we have had some decrease in prescriptions, we still, I keep going back to this graph, but we still are having this massive increase in overdose death. And I just really think we need to do more. And I think that the biggest thing that's missing from all of these plans at this point is opioid naivety. So far, barring kind of one of the guidelines, essentially all of the guidelines don't mention this idea at all. And so far, it's really not gotten a lot of traction in the community as an important concept. But to me, and I think thinking from the lens of a child psychiatrist in developmental psychopathology, these people are the most important people that we need to be focusing on. Because at baseline, normal people don't have much of a risk of developing an opioid use disorder. I mean, the general population is something like 0.6%, so most people are probably even less than that as far as risk. But as soon as we give them an opioid prescription, their individual risk skyrockets. opioids, right? For something like 4x, we don't really have great numbers, but it's probably even more than that would be my guess. And these people are really need to be our focus. And right now, and I don't have data to show this, but everyone that I've spoken to about this would agree. Right now, our priorities are kind of the opposite. And the way that most people prescribe opioids is if they find out that somebody is addicted to opioids, they very quickly start getting real protective of their prescriptions, and they don't give these people opioids, which I understand, and I think it's a somewhat reasonable response to it. But then if they find out that someone's not, and someone especially doesn't have a history of addiction and seems like a nice person and they like them, they're very cavalier with these medicines. I mean, I talk to people all the time who end up with 30 and 60 Norcos for some minor procedure. They end up taking 0 or 2 of them and then giving the rest to their friends or whatever. I mean, people with these specific people who are at highest risk of being exposed and developing substance use disorders are really very cavalier, and this is really the center of why I'm giving this talk, and I think it's in some ways very intuitive that this is how we should be operating, but it's really not the way that Western medical doctors are using opioids, or at least doctors in the U.S. are using opioids at this point, and I think it's crucial. And I think these people. I think we should be asking people consistently if they've used opioids and if they're naive to it. And if they are, then we should really be thinking about other ways to treat their pain as much as we can. It should really be a last resort, these opioids, like we do with a lot of our medicines in psychiatry that we know have real scary risks, benzodiazepines, neuroleptics, all these things. We try our best to use other things first. Because we're aware of the addictive potential and we're worried about it. And right now, despite all of this, I don't think that our colleagues in surgery and gynecology and primary care are nearly worried enough about their contribution to this crisis. And I think that as psychiatrists, we really have to sort of hold that flag. And some of you may be thinking, like, what about pain? Right? Like, pain is a big deal, and like those people in the 90s, they weren't wrong. There's still a huge pain epidemic in this country. We estimates of about 100 million people in the United States are suffering with chronic pain. I have a hard time believing that particular statistic, that almost 1 in 3 people in the U.S. are suffering with chronic pain, but that's the number that's out there, and they probably know better than I do. But pain is a big deal. There's no question about it, and I think. And what I'm arguing is not that opioids should not be used for pain. In fact, I think that they certainly have a role in managing both acute and chronic pain in some situations. What I'm arguing is that we should really be thinking more about other alternatives to treating pain. And I didn't want to present a list, but this is my only list for the presentation, but I just wanted to give a sense of all of the other things that we can do to treat pain. And NSAIDs and Tylenol are surprisingly effective, particularly when somebody's not already addicted to opiates. And these can be given in oral formulations and IV formulations alone and in combination. Things like SNRIs and tricyclics have been very effective, especially for chronic pain. Nitrous oxide and ketamine are for reasons that still kind of baffle me, almost totally not used in this country, despite incredible safety profiles and very low addictive potential. And outside of the pharmacologic realm, things like acupuncture and mindfulness have really surprisingly good evidence bases for their efficacy. And group and individual therapy has some evidence base. And we like that because we like that stuff, and very well might be more helpful than giving somebody an opiate every day. And going through this talk, I really kind of was thinking a lot about how psychiatry, what our role is in this process. Because right now our main role is to kind of treat them as they do, right? They get addicted, and then eventually they get siphoned into treatment, and we treat them. What I think is fine and important, and I think is probably going to be a bigger role as time goes on, but I think that we have another very important role here as the experts within medicine on addiction. I think that even though many of us feel pretty inadequately trained for addiction, all of our colleagues are even worse trained. Nobody outside of psychiatry is getting virtually any addiction training at all. And so, I mean, as sort of under-prepared as we feel for treating addiction, those guys are that much worse. And I think we have a really important role for advocacy in using our understanding of developmental psychopathology and the way that substance use disorders develop to inform policy and to suggest and to guide our colleagues in other fields on best practices for use of these medicines in taking into account their addictive potential. So I think that we really have to be advocates here, and I'm still trying to figure out how best to do that. But I think that we really do have an important role, not just in treatment, but in really encouraging prevention, and that's going to take persuading a lot of people in other disciplines. And yeah, I intend to try my best to do that. As far as takeaway points from this talk, the first is that this is just a huge problem. And I know we hear about it all the time on the news and stuff, but really until putting together this talk, I didn't have a great sense of the scale. And we can look at deaths, but even beyond deaths, the amount of suffering that's happening from opioid use disorders in this country is massive, and it's something that we really need to address. The second is opioid naive people being prescribed these medicines by physicians is a huge source of new addicts in this country, and we really have I think we really have to focus on them if we hope to actually turn this thing around. And the third is that psychiatrists really have a role in this, and psychiatry has been pretty avoidant around working with addiction, but we're in the best position of anyone to try to change practices of U.S. medical doctors in prescribing, and as the experts on addiction, I think we need to. Acknowledgements. My good friend Joe Freeman, who's an emergency medicine physician in New Orleans, who we spent a lot of time together on this talk and have spent a lot of the time over the years talking about stuff like this. And he was really invaluable in this. John Sikorsky for putting this together in the first place and also providing me some resources. And while I hesitate to put this, my mother, who is a pain management specialist at the VA, and we've been talking about pains for a very long time, and went through this and gave her stamp of approval and gave me a lot of ideas to add into this. Any questions? Yeah, I mean.
Mark, thank you for the fantastic talk, and it's definitely a very important topic. I have two questions. So first off, I probably have missed the point at first. I wonder, was those statistics including heroin cause death?
Heroin?
Mm-hmm.
Yeah, opioid in general. They were put together.
And is there a percentage diverting how much is coming from the opiate medications part, prescription part, and how much of it is coming from the heroin part?
Which numbers? The prescription numbers?
Probably the death.
The deaths are combined.
It's all combined, and we don't know the ratio.
There are ratios. I didn't want to have a super complicated graph in here. It looks like it's on the order of like a third coming from heroin at this point, and about 2/3 coming from prescription opioids of various kinds.
Gotcha. And the second question is, do you think that methadone or Suboxone will become the future opiates, just like falling into the same position, because we still don't have a massive number of reports about these two medications, since we haven't had a ton of experiences of using it for a long time, or for a very big population?
You mean that if they're going to end up being an equal sort of public health crisis?
Right.
It's a good question, and one that we really don't know the answer to, I would say. I mean, I think it's one of the big concerns about opioid replacement therapy in general, is that these people are still on chronic opioids, and we still only sort of understand the harms of chronic opioid use ignoring abuse entirely, we really have pretty poor data on how these meds affect our bodies. I mean, there's evidence that they have profound hormonal changes and bone density changes and mood changes and a lot of other things that are almost certainly true, but that literature is really not very robust and not very long term at this point. And as far as I know, I don't think of them as meaningfully intrinsically that different from other opioids. I mean, buprenorphine is obviously pharmacologically pretty different, but certainly methadone is really pretty similar. And so my guess would be that things that are harmful about other opioids would be for them too, but that overall it's still quite a bit safer for a lot of other sort of more complicated reasons.
So the numbers are truly disturbing, and I recognize, well, it was just a few years ago that the medical board made me take, I don't know how many hours, 6, 9, 10, 12, that people weren't getting any pain control, and that was really causing enormous amount of suffering. And, so we all know, it doesn't matter what, whenever there's a shortage, there's hoarding. So anything that you do that creates a shortage of access to pain medicines probably will result in hoarding. And once people have, a sufficient quantity to overdose, of course the risk of overdosing dramatically increases. So what I'm interested in is, how do other countries handle this? How does Germany handle this? How does Switzerland handle this? How does Holland handle this? How do they handle this? Do they just not give people opioids? Do they say just, go see your chiropractor, go for a walk, or what do they do?
I mean, I referring back to this list. I mean, I think in this country we've developed this sort of very direct connection between somebody's in pain and that somebody gets an opioid. And that's a pretty new connection. I mean, we're talking since the 90s, really not that long of a time. And I'm not as familiar by any means with how other countries practice pain management, but my understanding is they use a lot more NSAIDs, they use a lot more Tylenol, and those in combination. And yeah, non-pharmacologic stuff too. Go for a walk, go, talk to your family, go get moving, that sort of thing. Because they really want to avoid the opioids. But it's a good question. I would like to know more about how they actually practically do it.
Thank you.
Great talk, Mark. So with this list up and thinking back to your goal for prevention, I kind of had 2 comments and thoughts. The first one is how often or do providers in psychiatry and outside of psychiatry recommend these other kind of lower treatments, acupuncture, mindfulness, pain management, behavioral strategies in adjunct to, with opioids or Tylenol or whatever? Is that standard practice?
I think it's shifting, and increasingly it is becoming standard practice. I think as more and more people get concerned about how opioids have evolved in this country, people are more and more focused on other strategies. And also, and I felt like it was too much for this talk, but there's a growing movement that's saying these opioids, they don't even work for chronic pain. This ends up sort of like a lot of us feel about benzodiazepines in psychiatry. They sure do feel good at first, but pretty quickly, certainly on the span of years, you are worse off than you would have been if you never started with the opioids in the first place. And so more and more people are trying to avoid those opioids, and in people who are using opioids, try to do other things to increase functionality, increase things like exercise, and to taper people off the opioids, because in general, it seems like with most of our medicines, the side effect burden increases while the efficacy decreases with time. So yeah, I mean, more and more it's standard of care. Unfortunately, almost all of these other strategies are harder, right? They're a lot harder than filling out a prescription and handing it to them.
And then also training was my other question, is how easy is it for people to access somebody who's really good at helping them manage their pain and non-pharmaceutical?
It's hard, I think, especially, I mean, in places like San Francisco, it's maybe not so hard, but in the vast majority of the country, access to people who are really knowledgeable and competent in doing anything other than opioids in terms of pain has got to be rare. I don't know the numbers, but yeah, I think it's hard. I think it's an important point.
Another thing to add to your
Yeah.
prevention.
Right,
Yeah.
right, yeah.
Yeah, I was wondering if you could found anything in your research for this talk about why it's been skyrocketing, like mortality has skyrocketed in the last couple of years. I mean, just a little bit as like a leading question, I kind of wonder if you're going to say something about fentanyl.
Yeah.
And sort of what implications that has and what other factors you may have found that are contributing to that sharp uptick in the last couple of years.
Yeah, I mean, I wonder about fentanyl. I do think it's an important public health crisis internationally at this point, and has led to a really pretty insane number of overdoses, accidental overdoses especially. And you know, I don't really know. I do have a lot of thoughts about it, and have sort of thought about it a lot, but and there's not really data to guide us. I think one of the main things is that this kind of compounds on itself, and there's kind of a lag that happens as people, you know, you don't die after your first exposure to opioids. This kind of takes some time, and there's kind of a kindling process that happens with addiction as it gets worse and worse. And I think that a lot of folks who were exposed a decade ago are just now getting to the point where their substance use disorders are so bad that they're actually dying and overdosing, and that's sort of compounding. But you're right, it's really steep from like 2013 to 2016. And I'm not sure that really explains it all, and I do wonder about things like fentanyl, or also benzo use is another thought. A lot of these deaths are in combination with other meds, in particular benzos and alcohol. And I think that could potentially also, I don't know the numbers there, but my understanding is that benzodiazepines are also increasing in use, recreational use.
And another thing to add to this exact list would be local anesthetics.
Yeah, oh yeah, absolutely. Blocks also, and I mean, hypnosis. I mean, there's a lot of other stuff that can really work, and I think is important, right? Yes, sir, in the back.
You think about this ACEs score, and people who have family members who have had addiction.
Yeah.
As a screening mechanism, as a nurse practitioner, I don't have a VA license yet, and one of the reasons is this very topic. 17 years ago when I became a nurse, there's a real strong push to teach us about the fifth vital sign.
Yeah.
And I'm sure it was driven by pharmacology. Now,
sure
at this point, I'm a little shy about going forward, but I do think a lot of what's happening is, you know, there's a real need to treat psychological pain, spiritual pain, or other types of pain that people are experiencing, and opioids just becomes that avenue. And I wonder what ACEs, how that would look as a screening mechanism for who to prescribe opioids to and who to be a little more hesitant to have deeper conversations about.
Yeah, no, I think it's an important point. I would really just harp on the fact that there's no risk factor in the world that, especially a modifiable risk factor like exposure. And so even in somebody who has, you know, very low ACEs score and doesn't have a history of substance abuse, their biggest risk factor for addiction is going to be your prescription if you give it to them. And I think that there's an important role in kind of stratifying risk and maybe being more cautious with some and less cautious with others. But I really think that with people who have not yet been exposed to opioids, by far the most important thing is to try our best to avoid using them. But yeah, no, I think thinking about risk factors is also
Have the numbers
important.
increased for African Americans and Caucasians and Latinos and Asians?
Right now.
It's not. It's not. I mean, the numbers have increased. I think for pretty much all groups, but it's not equal. Especially whites have been recently hugely disproportionately hit by this for reasons that I'm sure are very complicated and I don't know the details of. But the risk is going up essentially in everyone, but really hugely disproportionately white people in this country, which I think is, not to get too political, but a big reason why it's become such a big deal. Opioid addiction has been a big problem in urban areas and in low SES populations for a very long time, and it's not until the last decade or so when physicians are sort of giving their stamp of approval on these drugs that sort of middle and upper middle class white people have become so affected by this epidemic.
The sociocultural change in the 90s was the introduction of asking what is your pain level as a fifth biomarker.
All right.
And of course, anybody has a pain about anything is going to register above 5 or 6, and then they're going to do a prescription.
Right. Yeah, right. Yes, sir.
And then looking at the sociocultural and historical part, I remember back, Daryl Nava used to talk about trends over time, with opioids and downers and uppers and the socioeconomic connections. Have you looked at that, or is that part of the thinking on this opioid epidemic? There's some...
I don't entirely understand your question.
Okay, so over time, certain drugs, uppers or downers, go up and down, and
Sure.
somehow that's related to the socioeconomic situations we live in.
Yeah, I wonder.
If there's been any...
One of the really interesting observations that I sort of kept out of this talk is just how heterogeneous this epidemic is in the United States. Places like the Bay Area are shockingly under impacted by this, whereas places like the South and like big parts of the Midwest, there are places where there is an opioid prescription every year. More than one per person in the in various counties will be getting opioid prescription. There are even places that are about 3 per person per year that are getting these prescriptions, and then other places where it's dramatically lower than that, like here. And I think that there's almost certainly parts of that that are from sort of the sociocultural milieu that those places are in. And I mean, I think opioids are incredible short-term antidepressants. People feel a heck of a lot better when they take them, and I think that that's almost certainly part of this.
Thank you.
Yeah, Summer.
It's also a multi-billion-dollar industry. So,
Yeah, it is.
like, I just sent you, I'm sure you've seen it, but the New Yorker article about the Sackler family.
Yeah.
Yeah, I
And-
get it.
Yeah,
I mean,
yeah.
it's so ironic because like I was at Cornell before,
Uh-huh.
and they're Sackler fellows in
Right.
psychiatry.
Absolutely.
And I mean, and wings of art museums and everything else, and like, but they've always hidden what their family business is.
And sublimation is a powerful thing, right?
Yeah, and I mean, I'm sure nobody wants this, but it is like good for business.
Absolutely, for their business, for sure, yeah.
And so.
And for our business in a way, in terms of psychiatrists.
Yeah, so anyway, it's just, but because I've been struck by, like, yes, you hear about it on the news, but I haven't really seen a public health initiative like I would expect with those numbers.
Yeah.
I mean, it's kind of like, I mean, it's big tobacco,
Right.
sort of, and you see commercials all over the place trying to reduce smoking.
Right.
But I don't see things that are like 2% of people who have opioids for the first time are going to become users.
Yeah.
It seems like if you educated the public to be scared to take them,
Right.
that should be sort of the first step. Like,
Yeah.
here's this prescription, but be careful because you might end up an addict and die.
Right.
Like, that would be maybe good, because I
I
don't
think
think
that's
that,
another huge
that
thing.
information is not imparted to people. Like, you get your wisdom teeth out, you get
Yeah,
an
right.
opioid, so.
Totally. Yeah, no, I wholeheartedly agree with you. I think education is another big part of this.
Yeah.
Okay, it's 1 o'clock, that's good. Well, Lance is good for the last one.
I was interested in researching this, how medical boards have responded. I know when I was in New Mexico, I had to take like 5 hours of pain management. Like everyone who had a DPA in New Mexico had to take that.
Wow.
And it actually went over non-opiate types of like, treating pain.
That's fantastic. I didn't realize that was a thing, but that's wonderful. As far as I know, it's not very broad. I mean, I certainly didn't have to in California, but yeah, I'm not sure sort of the status of that elsewhere. But it's a good thing. Okay, that's it. Thanks everybody for coming.